in the absence of broad ubiquitous testing, are we risking second wave of outbreaks possibly in the vastly under-tested rural regions of the state if we relax restrictions without an aggressive testing strategy and corresponding resources in place?
This is Scott Bookman, and we are aware of the need for testing. The governor is very clear that the state will not reopen until he has the capacity to make everyone safe, and he has really given us the charge to ensure that we have the capacity to do mass testing across the state. We are working with our local public health agencies, our healthcare partners, to identify locations so that we have the capacity to do mass testing across the state. We are doing everything we can, working with our federal partners and the private sector within the state, within the country, and internationally to gain all of the equipment and consumables that we will need to do mass testing across the state. And that really is a key pillar to our ability to move forward into our new normal.
Okay. It looks like that question was submitted twice, so thank you. Sam Tavachnik with the Denver Post. Both Latinos and African Americans are seeing higher hospitalizations, but Colorado's Black residents are dying at a higher rate compared to their portion of the population. Why might that be the case?
This is Rachel. I can take that question. So unfortunately, we know that there are, longstanding challenges associated with access to healthcare and also longstanding economic challenges associated with certain racial and ethnic groups in the state and across the country. And we do see those disparities play out in, the number of individuals in certain racial and ethnic groups that are particularly impacted, not just by COVID-19, but by many health challenges. And I think, unfortunately, we are seeing that in this pandemic as well. We are working to investigate what some of those challenges to those populations might be. We certainly know that access to healthcare can be one of those. And also, rates of chronic disease can be another factor that leads to more severe outcomes. So that work is certainly ongoing in the state.
This next question is from Ellis Arnold at Colorado Community Media. Are staff and visitors having their temperature taken whenever they enter residential and non-hospital healthcare facilities statewide, meaning nursing homes and all other types of group residential facilities that are included in the state's outbreak count? Are taking temperatures or other precautions required by the state?
This is Rachel. I can take that question. So we do certainly, together with CDC, have strong recommendations around using those screening practices, especially for nursing homes and residential facilities like that. Those are critical strategies to use to protect the residents of those facilities.
This question is from Benito Judas at Bloomberg News in Denver. Have any nurses, doctors, or healthcare workers died of coronavirus in Colorado or been hospitalized?
This is Rachel. I actually am not certain of the answer to that question. We'll investigate and happy to get back to you on that.
This question is from Jesse Paul with the Colorado Sun. Some county health departments have had to resort to testing residents on their own dime with their own personnel. They have neither the funds nor the manpower to keep this up. What is CDPHE doing to ease their burden and encourage primary care physicians to take on this work?
This is Scott. I can speak to that one. This has been a really unique challenge associated with COVID-19. The extraordinary PPE demands to do this testing safely has really taken testing out of the traditional places where it would normally be done, like in hospitals or doctors' offices, and really pushed it to public health at the local and the state level, where we have never really had that responsibility before. That's why you've seen these unique drive-through testing sites and all the other really innovative ways we've looked to try to increase the capacity for testing in the state. We are currently working with our local public health agencies and really developing a mass testing strategy with them. The goal is really to have the local public health work with healthcare providers, whether it's doctors' offices, federally qualified health centers or hospital systems to really determine the best way to do mass testing in their communities. And then, as I said earlier, CDPHE is doing everything possible to procure all the needed supplies and equipment to do this testing safely and at scale.
This next question is from Lily Tyson with KUNC. Data released yesterday shows that about half the deaths in the state are at nursing home and residential care facilities. Are these residents dying at the facilities, or are they being moved to hospitals? Are families allowed to remove individuals from nursing and residential care facilities that have a confirmed case of COVID-19, or are they required to stay and not risk spreading COVID-19?
This is Rachel. I can take that question. So obviously these outbreaks in long-term care facilities have certainly been a tragedy, and we do know that the individuals who reside in those facilities are at very high risk of severe disease, and we are working closely with those facilities to manage outbreaks. As far as the specifics of the location of deaths occurring, I believe it has been both. So individuals in these outbreaks have died in those facilities, but also those facilities are working closely with the providers that oversee their healthcare to ensure that patients are being transferred for healthcare when they need to be transferred for healthcare. As far as the question about are families allowed to remove individuals from nursing and residential care facilities that have confirmed cases, I am not aware of any restrictions in place that would prevent individual families from having their family members that are in those facilities leave those facilities. I don't know, Dr. France, if you have any additional information on that.
I think Dr. France might have had to drop off.
Oh, okay.
This next question is from Ellis Arnold at Colorado Community Media. At a news conference yesterday, the governor spoke about a graph that showed different case trajectories based on the amounts of social distancing. It also showed detected cases of COVID-19 appearing to, in Polis's words, plateau around 2,500 cases between late March and early April. That doesn't appear to match up with the state's graph at the COVID-19 website, which shows about 1,400 cases March 25th, increasing steadily to 5,150 on April 5th. What explains this discrepancy? Was the governor's presentation showing a hypothetical model?
This is Rachel. I can take that question. I think probably one of the major differences is really what date you are using to count cases. The modeling data that the governor showed is based on onset date. So that means when an individual developed symptoms. Much of the data that you see on our website is based on report date. So when that data or that case was reported to public health. And there's obviously a significant lag between the two. We know that, an individual first is exposed, then develops symptoms, then seeks testing, and then that test result gets reported to the patient, and then the test result gets reported to public health. So there's a lag in there. And so I believe the difference is probably that, the governor was showing a figure that had onset date in it compared to the figure you may see on our website that has report date on it.
This question is from John Herrick with the Colorado Independent. Where is Colorado at today in terms of social distancing as a percent? And what is the current infection rate or not? With this information, does the April 6th CU model still apply when trying to predict a peak?
This is Rachel. I can take that question. So I think first, just some semantics. So R naught is the basic reproductive number. And so that is a static value at the beginning of an epidemic. R, which is the effective reproductive rate, is really what is being changed over time with social distancing strategies. So certainly the model that was produced on the 6th does still apply today. If you look at the figure that the governor showed yesterday, we believe that we are somewhere between 70 and 80% social distancing achieved. As far as previously earlier iterations of the model, we were reporting on these different estimated values of R naught and effective R, but we really actually started using, because we have enough data now in the state, we've started using actual state data to show those curves. And so we still believe that the R naught in Colorado was probably somewhere around 3, so 2.5 to 3.5 is what we're estimating. And we don't believe that has necessarily changed. But the way we're modeling now is based on actual data, not predictions based on hypothetical R naught values.
Blair Miller with Denver 7 asks, do you have any data on essential worker industries that have been hardest hit by COVID? Example, hospitalizations or deaths in various industries like healthcare workers, grocery, etc.
This is Rachel. I can take that question. So the data we would have would be based on reported outbreaks. So obviously the healthcare sector is going to be has been very hard hit by COVID-19. We do know, especially in nursing homes, that there have been a number of outbreaks. In addition to that, we are also aware of specific outbreaks that have occurred in the meatpacking industry in Colorado, and we're working closely with industry officials in meatpacking to implement control strategies and to prevent ongoing transmission. So those are two scenarios that we're specifically aware of right now. We're obviously continuing to monitor for outbreaks across the state and aggressively investigate those as we identify them.
Ellis Arnold with Colorado Community Media asks, is it correct to say that when the stay-at-home order is lifted, COVID-19 cases will start to increase at a higher rate than we've been seeing under the stay-at-home order? And how much will that increase in the rate of growth of cases be mitigated by mass testing, contact tracing, more specific quarantines, and so on?
This is Rachel, and that is an excellent series of questions and exactly the same questions that we are asking right now. So the idea is when the stay-at-home order is lifted, that we would have alternative solutions to contain disease transmission. So instead of using a stay-at-home order, we want to use aggressive disease control strategies, isolation and quarantine, perhaps some other social distancing strategies that would be a little less than a stay-at-home order right now, and then other screening practices in businesses and nursing homes and other settings that could also limit transmission. So there's a variety of strategies we're looking at, and the challenge we have right now is trying to estimate how much each of those strategies might be able to limit disease transmission, and then really come up with the appropriate menu of options to use to really try and match what we're achieving right now with a stay-at-home order.
This next question is from Aaron O'Toole with KUNC. How full are the ICUs right now? Are you recommending team nursing or care teams as a way to meet demand?
This is Scott Bookman. Currently, we have great ICU capacity throughout the state. We do have some areas where we have higher case counts than others, which is impacting the number of patients in the ICUs. But right now, we don't need to take any mitigation strategies across the state, nor do we have any recommendations for our healthcare partners at this time.
This question is from Sam Tabachnik with the Denver Post. Does the state have the authority to fine companies that are not complying with state health guidelines?
This is Scott. The state has broad authority in our regulatory oversight of healthcare institutions, and we are evaluating all avenues to ensure that we have compliance with our directives.
This question is from Kathy Walker with KOA. Are you able to make any assumptions about the counties without COVID cases in Colorado?
It's a good question. I think those are all different counties. We are certainly aware of certain regions of the state that have implemented aggressive strategies to prevent COVID-19 from entering their communities. So I think they're probably pretty different from community to community across the state. They do tend to be smaller communities compared to obviously the larger communities across the metro area that have had larger, rates of transmission.
This question is from Lily Tyson with KUNC. The governor has said that the next 5 days are critical to his decision to lift the stay-at-home order. What data is CDPHE providing to the governor that could influence that decision? Did I read that one already?
I don't believe so. This is Rachel. I'm happy to answer. So the type of data we are looking at and sharing with the governor is exactly what was discussed at the press conference yesterday, and we've discussed already today, which is really trying to understand, the rate at which cases in Colorado might be declining. So we, at this point, believe we are at least in this plateau phase, but we are looking to see if over the next couple of days, cases will start to decline in Colorado. And then a really important predictor of, when we might be able to lift a stay-at-home order is that rate of decline of cases. We know that we need to decrease the number of cases that are occurring in the state to be able to successfully manage disease transmission with aggressive disease control strategies like isolation and quarantine and contact tracing.
This question is from Marianne Goodland with Colorado Politics. The database on non-hospital facilities released yesterday no longer includes some facilities earlier reported by CDPHE. Why?
This is Rachel. I am not certain of the answer to that question. It could be a difference in case definition, so how we were defining an outbreak early on versus now, but I'm just guessing. I would need to get back to you on that question.
This question is from Ellis Arnold with Colorado Community Media. When does the state expect to see the second wave of COVID-19, and when and how high will its peak be?
This is Rachel. I think the reality is it's too soon for us to know that. It really depends, I think, on policy decisions that are made over the next couple of weeks, and the ability for disease control strategies to control transmission with less social distancing in place.
This question is from Aaron O'Toole with KUNC. We've heard that doctors and nurses are being asked to take pay cuts at hospitals. What impact does this have on care?
This is Scott. I'll take that one. And while I am not aware of any of those specific incidents, we do know that the COVID-19 is having an impact on all areas of our society, including our hospitals. And that's the governor's goal, to reopen as quickly as possible to ensure that we can get our economy back on track.
This next question is from Mike Rice with KOA Radio. Given the growing financial strain on the healthcare industry, when will hospitals and medical facilities be able to resume with regular business, including elective procedures?
This is Scott. I'll take that one as well. So again, we know what conditions need to be in place before we can safely reopen and start moving back to our new normal. That includes the ability for our hospitals and medical facilities to do regular business. The impact that those elective procedures have on PPE and on bed availability are a critical component to being able to safely reopen. And so we will evaluate that as a bigger part of the picture.
This next question is from Marianne Goodland with Colorado Politics. Does the CDPHE plan to release the raw data on the CDPHE website or database?
This is Rachel. So we are able to accommodate data requests. That we obviously have privacy restrictions that we are working within. And so the amount of data that we are able to release is limited because we need to protect individual privacy. And so when we start getting into small numbers of cases and having that data, sliced and diced and looking at different age groups and racial and ethnicity groups and smaller geographic areas, that's really when that data can become identifiable. And so it's a priority for us to ensure that we are maintaining privacy for individuals that are infected and for the families of individuals that have family members that have died of this infection.
This next question is from Elena Rivera with KRCC News. Interested in knowing specifics about communities in Southern Colorado and how rural hospitals are dealing with the virus.
This is Scott Bookman. We are working closely with hospitals across the state to ensure that they have the capacity that they need to respond to COVID-19 patients. And at this point, in our conversations with those hospitals, we are not aware of any that are having or being overwhelmed by the number of patients that they are seeing.
This question is from Chris Vanderveen. How confident is CDPHE that the state will have adequate testing capability if and when the governor starts to open up the state?
This is Scott Bookman. Having enough testing capacity is one of the key requirements of opening up the state. Until we have locations and partners and all of the equipment that we will need to do so, we won't really be able to implement our testing strategy, which is just one of the foundational elements of reopening.
This question is from John Herrick with the Independent. Are any hospitals using crisis standards of care?
This is Scott. The only crisis standards of care that are being utilized at hospitals are around personal protective equipment. And these crisis standards of care allow hospitals to reuse equipment that they would not normally do under normal times. Other than that, there are no crisis standards of care in the hospitals.
This question is from Carrie Harden with the Steamboat Pilot. In terms of flattening the curve, how accurate is the data if we can't test everyone with symptoms?
This is Rachel. I can take that question. So as far as, the modeling work that is being done, that work is estimating that approximately 30% of cases are being reported to the state. And the estimates, the projections, and, the predictions of plateau versus decline in cases those predictions are being made with an understanding of underreporting. So that is factored into the model and factored into those predictions.
This question is also from Chris Vanderveen with 9 News. As an addendum to my previous question, we all know that mass testing will be a key to the effort to start to reopen the state. What specific criteria are you looking at to tell you that we have enough testing to accomplish even a gradual reopening?
This is Scott Bookman. So our goal is to have a minimum of one testing site in each county. Obviously, that in our rural counties, one site may be enough for volume, but we may need to move it around based on the geography of those counties. In our larger counties, by population, we know that we'll need multiple sites. And then we also will need to have all of the equipment, that is swabs and viral transport media and personal protective equipment to safely open these sites for everyone.
This question is from Sophie Quinton with Stateline. Why did CDPHE only recently begin releasing information about the race and ethnicity of COVID-19 patients?
This is Rachel. I can take that question. So our ability to report data on race and ethnicity really depends on that data being reported to the state. And so we have been making progress over the last several weeks about getting more complete race and ethnicity data from providers and laboratories that are reporting this data to us. In the absence of those, that data being reported to us, we really need to go through significant efforts to get that data, which includes, contacting patients by phone and interviewing them, or reviewing medical records to try and get that information. And it's unfortunately very time consuming. And so our strategy going forward is to really try and get that data from the beginning, from the reporters that are reporting cases to us.
This question is from Jensen Worley with the Denver Business Journal. Can you give an update on the work of the Innovation Response Team is doing? Are there any results or progress that can be shared?
This is Scott. The Innovation Response Team is working across a number of different areas. They've been heavily engaged in our mass testing strategy, working diligently to get supplies that are really constrained right now. They were working on ventilators. They continue to work on PPE. They've got a huge focus on getting the testing equipment. And then they're also looking at innovative ways to support people who are in isolation over quarantine and periods. And then finally, really looking at what our new normal will look like.
This question is from Ray Bichelle with KUNC. And she asks, can you give a breakdown of what % of diagnostic tests the various labs and companies have done for Colorado patients so far? LabCorp, Quest, etc.
This is Scott. I do not have that information available to me at this time, but we can look and see if we can get it. And if we can, we can supply it.
This is Rachel. I would just add, sorry, I just want to add that I think it's quite helpful to see that, as we would expect as this epidemic has progressed, early on, much of the testing was being done by our state public health lab, but increasingly we are seeing much more of the testing being done as it should be done in commercial laboratories.
This next question is also from Ray Bichelle, and the question is, does Colorado have a testing czar, somebody within CDPHE whose entire job is to focus on testing? If so, who is that person?
This is Scott. We do not have a single person identified as a testing czar. We have multiple team members working across the innovation response team and within CDPHE to focus on developing mass testing strategies across the state.
This next question is from Marianne Goodland with Colorado Politics. How is the CDPHE managing outbreaks, given that the number of facilities with outbreaks has more than doubled in the past 10 days?
This is Rachel. I can take that question. So the way that we work on these outbreaks is first the outbreak needs to be reported to us. So that's obviously a really important part. And once the outbreak is reported to us or local public health, we work with the facility to try and understand why transmission might be occurring in the facility, what risk factors might be for cases developing, and then also risk factors for severe outcomes in the cases that have occurred. In healthcare settings, a really important strategy is making sure that infection control practices are at the levels they need to be to prevent additional cases from occurring. And that work is ongoing. It's work that we've been doing for a long time. I think, unfortunately, these are really high risk settings, especially when you look at long-term care facilities. And we are working diligently and investigating new strategies that can be implemented to prevent these outbreaks from occurring.
This question is from Chris Vanderveen. Now that Colorado Hospital Association is reporting daily case counts, can we expect CDPHE to modify how it reports hospitalizations moving forward? CDPHE is still relying on cumulative numbers as opposed to day and time count.
Yeah, this is Rachel. I mean, I don't know if I would say that I think that they're additive, right? They both have different information that they contribute, and we think that having this daily case count of hospitalizations that CHA is providing is a wonderful resource, and we're using that information and think it's quite important. But at the same time, we also think it's important to continue to track cumulative data on hospitalizations, and those data are collected in very different ways. As I've mentioned previously, the data that CDPHE is collecting on hospitalizations also involves collecting lots of additional information about that person's hospital stay and their risk factors. And so I think there's different purposes for different surveillance systems. And our goal right now is to use all of the surveillance systems and all of the data we have available to us to guide our decision making and really try and understand the impact of the outbreak here in the state.
All right, well, thank you very much. It's right about 11:30 here. So we're going to go ahead and stop taking questions right now. But before we sign off, I'll have both Rachel and Scott say and spell their names and repeat their titles for you all. Scott, would you mind going first?
Sure. Scott Bookman, SCOTTBOOKMAN. I am the incident commander for CDPHE.
Rachel Herlihy, RACHELHERLIHY, and I'm the state epidemiologist.
Wonderful. Well, thank you everyone for joining us this morning. Have a great afternoon.
Thanks.